Good morning, everyone, and welcome to this morning's webinar on racial disparities in public health. This is the third installment in a four-part webinar series presented by the Midwestern Legislative Conference's Forum on Social Justice. My name is Laura Cleaver, Senior Policy Analyst with the Midwestern Office of the Council of State Governments. One of our roles here at CSG is to provide staff support to the Midwestern Legislative Conference and its standing committees and other entities, including the MLC Forum on Social Justice. On behalf of CSG and the entire Midwestern Legislative Conference, it's a real pleasure to welcome you all this morning. Before we get started, let's briefly review a few items. First, a reminder that today's webinar is being recorded, and a copy of the recording will be made available on the CSG Midwest website. Second, we ask that you please mute your audio while the presenters are speaking to help reduce background noise. Third, we hope this will be an interactive session, so please be ready to participate in the discussion or ask questions following our guest presentations. We have a half an hour at the end that we especially hope that you will be ready to jump in and share your own experiences and ask further questions. You're also welcome and encouraged to use the Zoom chat to ask questions or share comments at any time. Now I'm pleased to introduce to you Michigan Senator Marshall Bullock, who is among a group of legislators who have been working to help establish the MLC's Forum on Social Justice. Thank you, Senator Bullock, for agreeing to facilitate this morning's webinar and for your work on behalf of the Forum, your state, and the region. Senator Bullock will take it from here. Senator Bullock, you're muted.
Double click. Well, greetings and thank you. Thank you.
Sure.
I did a whole lot of talking in there. I thank you, Laura, and I thank you for having the confidence in me to be your host of this particular forum. I'd like to welcome all of you as attendees and just tell you a little bit about myself. I am the chairman of the Michigan Legislative Black Caucus. I represent a great deal of Detroit as a senator and some of our downriver cities, but due to redistricting, that will kind of change it. So, and I sit on the coronavirus task force for racial disparities, and I also am the vice chair of Family, Seniors, and Veterans, where a lot of this social justice issues comes our way. And so just wanted to point that out. So we want everybody to participate, ask questions as we get through some of our speakers. And by way of background, the Midwestern Legislative Conference Forum on Social Justice was established by the MLC Executive Committee to provide a new standing forum and opportunities for our Midwesterner legislators to discuss a wide range of social justice issues, including economic equity, systematic racism and discrimination, racial disparities in public health, education and corrections, police reform, voting rights, and much, much more. Our forum members will have gathered on our state and our provinces from Canada in efforts to address social justice issues, identify best practices among us, develop recommendations for consideration by the Midwestern Legislative Conference as appropriate. The forum also seeks to provide professional development training opportunities for our Midwestern legislators on topics such as implicit bias, how to talk about race, and strategies for building racial divides, among others. The forum is open to membership and participation by all interested in the Midwestern legislators, and its leaders and governing structure will eventually be determined by forum participants themselves. In the meantime, the forum's initial steps are being guided by our steering committee that includes legislators from across the region, and I'm pleased to serve as a member of the committee. And today's webinar on racial disparities in public health is the third in a four-part series of virtual events focusing on some of the key social justice issues previously identified by the Forum Steering Committee as high priority subjects. The last installment in the series next month will explore police reform. The webinar will include an overview of healthcare disparities today and efforts by states to address these inequities, followed by case studies from two states, Kansas and Illinois. We're pleased to have four outstanding presenters with us today. Samantha Artiga with the Kaiser Family Foundation, Dr. Tiffany Anderson and Bruce Jordan from Kansas, and the great Senator Maddie Hunter from out of Illinois. Please note this morning that we'll have some time after each presentation to hopefully have some conversation questions about each segment, but then at the end we'll be prepared to jump into questions and comments and observations later. So first up, we're going to have Samantha Artiga, who serves as the Vice President and Director of Racial Equity and Health Policy Program at the Kaiser Family Foundation, or KFF. And in this role, Samantha leads the Kaiser Family Foundation work to provide timely and reliable data, information, and policy analysis on health and healthcare disparities affecting people of color and underserved groups, and efforts to advance racial equity in health and healthcare. Her work focuses on the intersection of racism and discrimination, social and economic inequities in health. She also has conducted extensive work related to the health and healthcare needs of low-income populations and immigrant families, and previously served as the Associate Director of the Kaiser Family Foundation's program on Medicaid and the uninsured. Samantha holds a master's degree in health policy from George Washington University, and I want everybody to welcome Samantha Artiga.
Oh, thank you so much for that kind introduction. I'm really pleased to be able to be here with you today and to share some of our work from KFF. I want to start with a little bit of background on my organization for those of you who may not be familiar with us. Next slide. So KFF, or the Kaiser Family Foundation, is a nonprofit organization focused on national health issues, as well as the US role in global health policy. Really what we provide is information to help inform policy. And we do this across a number of different lines of work, including policy analysis, polling and survey research, journalism through our news service, Kaiser Health News, as well as public information campaigns, including the campaign Greater Than COVID that has been ongoing over the course of the pandemic. Senator Bullock already did a tremendous job introducing my role with the Racial Equity and Health Policy Program and some of the work we do there. But again, you can see some of our focus issues there. Next slide. I wanted to start today by grounding us in a little bit of a discussion about what we're talking about when we're talking about health and healthcare disparities. And really, these are differences in health, such as higher burden of illness, injury, disability, or mortality, as well as differences in measures like insurance coverage, access and use of care, and quality of care. And these differences are closely linked with social, economic, and environmental inequities. These disparities, as we'll talk about today, really arise from a complex and interrelated set of factors at many different levels, including the individual level, the provider level, the health system level, the societal level, and also are driven by a broad range of economic factors. Today, I'm going to be focusing my remarks on disparities through a racial lens, but it's important to recognize that disparities occur across many dimensions, including socioeconomic status, gender, age, disability, sexual orientation or gender identity, as well as geographic location, among others. And often those factors will intersect. Individuals don't just fall into one of these buckets. And although disparities have been recognized and documented for decades now, they remain a longstanding and persistent issue. Next slide. So even before COVID, we saw that people of color fared worse than their white counterparts across many measures of health. What you're seeing here are findings from an analysis where we examined over 50 measures of healthcare access and healthcare use, as well as healthcare outcomes. And what you see are that Black and Hispanic people fared worse than their white counterparts across the majority of these measures. These included indicators like health coverage, ability to access needed care, maternal and infant health measures, as well as measures of chronic disease. American Indian and Alaska Native people also fared worse across many of these measures, but we're also missing data for them on some measures, so we don't have a complete picture of their experiences. There's even more incomplete data for Native Hawaiian and other Pacific Islander people for whom we really lack sufficient data to understand their experiences. And as you can see here, as a broad group, Asian people tend to fare better across many measures, but these broad data often mask underlying disparities among subgroups of the diverse Asian population. Next slide, please. As you've heard over the course of the pandemic, I'm sure, COVID-19 has really exposed and exacerbated these underlying disparities in health and healthcare that existed before it began. Here you can see that over the course of the pandemic, American Indian and Alaska Native, Hispanic, and Black people have suffered more illness and death related to COVID-19. This reflects those underlying inequities that place them at increased risk for exposure to the virus, as well as increased risk of illness and death if they contracted it. And these impacts of COVID, in terms of disproportionately affecting people of color, are likely to lead to widening disparities in the future unless action is taken. Next slide. So when we look at the factors that drive disparities in health and healthcare, some of those factors do sit inside the healthcare system, things like whether or not you have health insurance coverage, your ability to access providers, how many are in your local community, how easy are they to get to. But many social and economic factors that sit outside the healthcare system play an even larger role in shaping our health. These factors, often referred to as the social determinants of health, include things like housing, access to healthy food, employment, access to and time to use green space. And so these inequities across these broad social and economic factors, which are rooted in racism, also drive disparities in health. Next slide. Focusing in on those factors that sit inside the healthcare bucket, we see that since the inception of the Affordable Care Act coverage expansions, including its expansion through Medicaid and the establishment of the new ACA marketplaces with subsidies for lower income people, there have been large gains in coverage across all racial and ethnic groups. Larger gains for people of color have helped to narrow some of the disparities we saw in health coverage, but differences persist and people of color still remain more likely to be uninsured. Next slide. We also see that Medicaid plays a key role in helping to mitigate disparities in health coverage for people of color by filling gaps in access to private coverage. This role increased under the Affordable Care Act with the Medicaid expansion to low-income adults. Today, you see that Medicaid is a major source of health coverage for people of color, covering at least 1 in 3 American Indian and Alaska Native, Black, Hispanic, and Native Hawaiian and other Pacific Islander people. And the program plays an even larger role for children of color, covering over half of Black, Hispanic, and American Indian and Alaska Native kids. Next slide. In addition to helping to reduce disparities in health coverage, a large body of research shows that the ACA Medicaid expansion has had a range of other positive effects, including increasing access to and use of care, increasing affordability of care, as well as some positive impacts on health outcomes. Next slide. However, to date, not all states have implemented the Medicaid expansion. In the 12 states that have not expanded Medicaid, over 2.2 million low-income adults fall into a coverage gap. These adults earn too much to qualify for Medicaid, but not enough for the marketplace subsidies, which begin at 100% of the federal poverty level. As you can see in the slides here, this coverage gap disproportionately affects people of color. Most of the states that have not yet implemented the expansion are in the South, which is home to larger shares of the Black population. And overall, nearly 6 in 10 people in the gap are people of color. As such, continued take-up of the expansion in these remaining states is one step that may help to address disparities. Next slide. Given the large role Medicaid plays for people of color, states can take up a range of other options that may also help to address disparities through their Medicaid programs. For example, just as of this month, states have now the option to extend Medicaid postpartum coverage from 60 days to 12 months, which may help mitigate coverage disruptions for pregnant people in their postpartum period. As of last week, 13 states have already implemented this option, and additional states are planning to implement in the near term. Next slide. We also see that many states have taken up options to extend Medicaid and CHIP coverage to lawfully residing immigrant pregnant women and children without a 5-year waiting period. Beyond this, some states are taking actions to expand coverage for immigrants, including through take up of the option in CHIP to cover unborn children, which extends coverage to low-income pregnant people regardless of their immigration status. And some states are also implementing fully state-funded coverage programs to cover low-income people regardless of immigration status. Next slide. Beyond taking options to expand eligibility, a growing number of states are also linking financial incentives, such as performance bonuses or penalties, capitation withholds, or value-based payments to health disparities related metrics. Most of this work is being done through states' Medicaid managed care delivery systems. And these can include things like collecting data on race, ethnicity, or social factors, or setting disparities related quality measures. Next slide. Outside of Medicaid, states are taking broader actions to address racial health disparities. And I'm not going to go into details here because I think you're going to hear about some of this work from our next presenters. But some examples of some of these broader actions include the establishment of health equity task forces, offices or cabinet positions, increasing data collection and reporting to better measure and address disparities, establishing health equity metrics or conducting health equity impact assessments, and establishing training requirements for healthcare workers on bias disparities and or equity. And last, providing grants to providers or community-based organizations, particularly those that are serving underserved groups. Next slide. As I begin to wrap up my remarks, I think it's important that we recognize that addressing disparities is not only important from a social justice standpoint, but also for our nation's overall health and economic prosperity. Underserved groups experience higher rates of illness and death that result in unnecessary costs and limit our overall health as a nation. Moreover, as the population becomes increasingly diverse, it will become even more imperative to address disparities. And as I noted at the outset, addressing the disparate impacts of COVID-19 and ensuring equity in COVID-19 vaccination is going to be important for preventing against further widening of health disparities going forward. Next slide. And finally, given all the attention there is now on disparities, it really is a pivotal time, not only for recognition of disparities, but for action to advance equity. Some of these actions might include prioritizing equity and directing resources to address underlying inequities in structures and systems across sectors, not only in healthcare, given that health is driven by such a broad range of factors. Increasing the diversity of the healthcare workforce, as well as diversity in research, including things like clinical trials. Increasing the availability of high quality disaggregated data to understand disparities and experiences across groups, and then using that data to inform actions and policies. Also establishing measurable goals for health equity and incentives and accountability for meeting those goals. Lastly, building on and supporting existing community resources and strengths. Often the best knowledge and best resources can come directly from the communities themselves. And with that, I'll close and I look forward to our continued discussion. Thank you.
Well, thank you, Samantha. That was some really, really, really great information. And we will have a few minutes, I think, to take a question or two. So please participate, enter your questions into the chat box or raise your hand to be identified. But I will say this, as the chairman of the Michigan Legislative Black Caucus, our 4 priorities are in line with the MLC steering committee. And the first one is healthcare disparities. And while the conference next week is about, next month is about law enforcement reform, ours is criminal justice reform, or we try to rebrand it as peace and justice. The other 2 are education inequities and workforce labor, economic development, inclusion. But here in Michigan, back in April 2020, when we created the task force on racial disparities, I put forth a resolution to declare racism a public health crisis. It didn't go far. However, the governor signed an executive order recognizing and addressing racism as a public health crisis, and then created a Black Leadership Advisory Council and put the onus on Health and Human Services to make health equity a major goal, because equal's not equitable. You know what I mean? So they're not the same thing. And so that required implicit bias training for all of the states. So do you have anything to address about implicit bias training?
Well, I would actually just go back to say that all those other topic areas that you indicated that you'll be focusing on, so peace and justice, education, those all are going to play a role in efforts to advance equity, right? So we cannot be addressing health equity within the silo of just the healthcare system. And so I think it's fantastic that this work is occurring across sectors. And to the extent that the work can be coordinated and collaborated across sectors, that will do even more to help drive equity. So I think, again, that cross-sector work is going to be key as we go forward here and really try and move from recognition to action.
Yeah, so it takes everybody to be at the table. So I don't see any questions, and I know one of our next presenters has a hard stop. So I will go directly into introducing Dr. Tiffany Anderson, who is the first African American female superintendent of Topeka Public Schools, and she's been a public school educator for 28 years, with the majority of that time as a superintendent. In addition to her role as superintendent, Dr. Anderson advises Kansas officials on post-secondary policies, equity policies, and legislation. And in 2019, Kansas Governor Laura Kelly appointed Dr. Anderson to the Post-Secondary Technical Education Authority, the TEA, as part of a Kansas Board of Regents. And in 2020, Governor Kelly appointed Dr. Anderson to co-chair the governor's Kansas Commission on Racial Equity and Justice. Dr. Anderson is a fierce advocate for equity, and in 2021 was a voice for the nation's educators, testifying in Congress on the digital divide. And 2016 and 17, national documentaries were created about Dr. Anderson's work addressing poverty and transforming communities, among other awards. In 2021, she received the Dr. Martin Luther King Jr. Living the Dream and Living Legacy Awards. She earned her undergraduate degree and later her doctorate from St. Louis University in 2001. And our other presenter, David Jordan, served as a member of Kansas Governor's Commission on Racial Equity and Justice and chaired the commission's healthcare subcommittee. He is the president of the United Methodist Health Ministry Fund, joining the fund in February of 2018. And before joining that fund, David served as the executive director of the Alliance of Healthy Kansas, a coalition of over 100 organizations working to improve the health and access to healthcare in Kansas. David oversaw the Alliance's operations and the effort to expand CanCare, Kansas Medicare program. He holds a master's in public administration from the University of Kansas and a bachelor in speech communication from Emerson College. So without further ado, welcome Dr. Anderson and Mr. Jordan.
Thank you. It is a privilege to be here with you this afternoon. As Commissioner Jordan and I share this presentation at the very end, we'll open it up for questions. As was mentioned, I have a bit of a hard stop, but somewhere around 10:50, if I depart and you have more questions, Commissioner Jordan will be staying on to answer those. So let me share with you a little bit about the commission. The governor signed Executive Order 2048 on June 24th, 2020, and it formed the Governor's Commission on Racial Equity and Justice. She asked that the commission study issues of racial equity and justice across systems in Kansas. And so we were first focusing on policing and law enforcement. The commission includes perspectives from the criminal justice system, education, healthcare, and advocacy organizations. This is not a commission on criminal justice reform. It is, however, focused on broad issues of racial equity in Kansas, which includes some elements of the criminal justice system, but it's not tasked with a comprehensive study of that system. So let me give you a little bit of history and background as we look at the commission and learn a little bit about it. Let me make sure that I'm following along with where you are. The commission submitted its very first report to the governor on law enforcement and policing, and that was December 1st, 2020. That report included over 60 recommendations to the state agencies, to legislators, to local government on how to improve racial equity in Kansas around policing. Following that report, And my apologies, I don't know if it's raining there, it's raining here, so I'm going a little bit of in and out on my end, so my apologies for that. Following that report and studying the initial topic, the commission heard repeatedly about overlapping issues, and these were issues in communities of color across the state. These issues all connected to the social determinants of health, and those specifically really focused on the various subcommittees that we ended up breaking up into: economic systems, education, and healthcare. Those were our three areas of primary focus.
Great. Thank you, Dr. Anderson. As part of our work on the Governor's Commission on Racial Equity and Justice, we really wanted to center our learning on engagement of both state and national experts, but really leaders and community members, most importantly, throughout Kansas. So the second phase of the report, as Dr. Anderson had highlighted, really was informed by the 60 community meetings around law enforcement and criminal justice, recognizing those issues were inextricably linked to economics, healthcare, and education. We held meetings, listening sessions, presentations. We took information from these meetings and developed the recommendations that we had in total, which we'll get into. I think we had over 160 recommendations that touched on many of the topics that Samantha had highlighted in her previous work. The commission also solicited feedback via social media. On this next slide here, you can just see how we promoted the contact information on the governor's YouTube page, on Twitter, on Facebook, and regular emails. We really want from Kansans and to get their feedback. And the two co-chairs and I and the governor's staff regularly responded to emails. So it's really an inclusive environment that's centered on feedback from community members.
So let's talk about these recommendations. And we didn't put all the recommendations in here. We're just highlighting some of the recommendations that we included, really focused on the areas that we're talking about here today. So we're going to start with policing and law enforcement. And one of our recommendations was to expand Medicaid to provide mental health and other healthcare coverage to populations not currently covered. So you see, law enforcement and community members and leaders, they all agree that there needs to be greater access to behavioral health care. It is a criminal justice issue. Many law enforcement encounters were the result of substance abuse or mental health issues. Increasing access to early intervention options by expanding Medicaid in Kansas would result in improved policing outcomes immediately. Expanding Medicaid would also reduce the state federal general fund spending on law enforcement and on behavioral health. The other recommendation was regarding support and finance the use of mobile crisis response models. This included co-responder and virtual co-responder models to assist law enforcement in responding to behavioral health calls and stops. Mental health professionals who ride with and work alongside law enforcement officers can contribute to positive outcomes and promote treatment over incarceration for individuals. These are individuals that are experiencing mental health crisis situations, and Kansas communities really should implement appropriate co-responder programs where possible. The next area that we really looked at that we included in here really talks a little bit about the social determinants of health. And as was mentioned earlier, this area for us was really kind of the core foundation from which we focused on. So universal equity policies were one of the recommendations. And here are some examples of what that can look like. We suggested to encourage government policies and enact legislation that requires bias and equity analysis of policy decisions and legislation at every level. Similar to the process of reviewing fiscal notes and informing policymakers about financial impacts of proposed legislation, or requesting economic impact statements on relevant bills, we're saying that the legislator should adopt a procedure for developing and considering equity analysis and impacts of any policy change. That would change directly some of the outcomes we believe individuals are seeing or could potentially see in the future. Maternal and child health recommendations included developing a payment policies to reimburse community-based providers, such as community healthcare workers, home visitors, doulas, lactation consultants. That's just to name a few. The Kansas Department of Health should adopt programs and payment policies that prioritize infant and early childhood mental health by paying for evidence-based didactic care of family therapy and parenting programs. Additionally, the Kansas Department of Health should explore team-based primary care, high-performing medical homes, and comprehensive home visiting as suggested strategies to support the two-generation care model.
One of the other areas that the commission looked at was the economic systems and the tax systems. One thing that was highlighted through our research and our experts is that Kansas ranks near the bottom of the nation in drawing down federal funds. We rank 46 in the country, according to the Pew Center on the States. So we recognize we need to draw down federal funds to better finance these critical services to address longstanding disparities that exist within health, education, and economic systems in Kansas, and to really start addressing root problems. Beyond just drawing down more federal funds through programs like expanding Medicaid and getting rid of administrative barriers that prevent access to safety net and work support programs like TANF, SNAP, and childcare subsidies, we really recognize the need to understand the perspectives of people of color and accessing COVID-19 dollars in the short term. And we sort of made a strong recommendation that as entities look at implementing direct relief and allocating discretionary funds, they should create structures that bring people of color and communities of color disproportionately impacted by COVID-19 to the table where decisions are being made, and consider their perspectives as we allocate the ARPA dollars and other federal funds. The other recommendation was to direct federal funds using a broad interpretation of health that includes the social determinants of health and considers health equity in the distribution of those funds. So, I think we made progress in this realm in terms of the SPARK process. It considered both social determinants of health and whether or not there was recommendations made by the Commission of Racial Equity and Justice as decisions are made in determining these funds. Hopefully, the coordination that resulted from the distribution of the federal funds related to COVID provide a lasting example for distribution of other federal funds and help us continue to draw down more federal funds to support core state services so that state general funds are not as scarce as they are currently in Kansas.
The next area is behavioral health, and I'm not sure if Commissioner Jordan was going to speak to this particular slide. So I'll just begin talking a little bit about behavioral health. We really focused on, in addition to funding, really expanding telehealth and what telehealth looks like. As a school superintendent, this impacted us directly, and certainly at the end we can address questions. But really, when you talk about behavioral health, really expanding telehealth access and codifying regulations that expanded that telehealth from mental health. So Kansas, like many states, expanded access to telehealth services in response to COVID, but the policy changes included payment parity and use of personal devices, the ability to initiate services at distant sites, making it easier for patients to access services and providers to provide services. But those things should be made permanent. This shouldn't be a COVID thing. This is really an equity issue that continues before COVID and after COVID. And that's what we're suggesting. The other area is ACEs and really inter-family violence. At the very end of this, if there are any educators that are on the screen, in Topeka Public Schools, this isn't on this slide. We want to share that, just one basic example. We began incorporating ACEs even in the way that we register young people, and we haven't seen a student suicide in 4 years. That's possible anywhere. In our recommendation here, we talked about just inter-family violence and improving coordination and partnership to increase prevention services and to guard against ACEs. For those that aren't familiar with what that is, that's adverse childhood experiences. So we're suggesting to promote and fund partnerships between the early childhood sector, behavioral health professionals, the private sector, law enforcement, improving access to services using preventative services. We do a lot of reactive kinds of things. We're really focusing on prevention as a key to reducing the interaction with the justice and child welfare system. So this should include payment policies and funding for care coordination services, pediatric care coordinators. It could include community health workers and just other culturally competent professionals to coordinate services for young children and their caretakers. Those are some of the key recommendations. If you want to see the entire report on this very next slide, it shows just the link if you want to go to that. The recordings from the meetings, the learning sessions that were held, all are there, as well as the documents. We also included links to other states and what they're doing that were really kind of islands of excellence, if you will, or exemplars. So we encourage people to look at that report as well. Commissioner Jordan's going to talk a little bit about the progress that we've seen since the report.
Thank you, Dr. Anderson. You know, like so many commissions, we really wanted to make sure progress was being made with these recommendations. I think, you know, we engaged a lot of groups. We built a lot of momentum on these issues. There's a lot of work to be done. And we've laid out, I think, a good roadmap to follow in terms of local action, state administrative action, and legislative action or recommendations. Our work concluded formally at the end of December, but many of the recommendations were carried forward into budget proposals, both in the governor's budget and the legislative budget, and ultimately were included in the budget that was signed just last week by the governor. These recommendations aligned with the restoration of higher education funding, which was included as a recommendation in the education subcommittee, increasing state funding for housing, which was an economic equity priority to help better dedicate funding towards the development and renovation of moderate and low income housing, increased funding in the Office of Broadband Development, you know, to start tackling that digital divide and digital equity issues that exist both within health, education, and the economic arenas, provide $3 million in scholarships for aspiring teachers to attend Kansas universities, providing $35 million in matching funds for economic development and jobs in the aircraft industry. And then there was many health priorities that were included in the budget. Next slide, please. One of the really exciting pieces from the maternal and child health end, to build off of Dr. Anderson's comment, really taking the preventive action, the earliest start in life. The governor's budget extended postpartum coverage from 60 days to 12 months, which will help address the Black maternal mortality crisis, as well as provide access to routine care, improving health for children and mothers, and as well as reducing interaction with the child welfare system. So this was an important health access and budget priority that was recommended by the commission and that many members helped make a reality in the budget. The budget also provided for additional EMS support, adult dental services, and preventive health care that was included in the healthcare recommendation. Additional funding for the Universal Home Visiting Program, funding for the evidence-based juvenile justice prevention. Again, many of these investments were in children and families, were in line with and included action from commission members and groups that advocated for it. So while there was a lot of challenges during our state legislative session, there was bipartisan support for many of the commission's recommendations and investments in children and families in Kansas that will help address longstanding disparities. But there's more work ahead as we think about payment structures and the reprocurement of Medicaid and many legislative challenges ahead. But we do want to celebrate the progress that we've made in this period of time.
That really concludes the slides that we have. We're going to open this up to questions, and we know you may also have questions for the last presenter and us, so we'll just wait for those to come in. But let me tell you something, as he talked about budget, you know, I always say, if you want to know someone's priorities, and one of our other commissioners have shared this as well, that if you want to know someone's priorities, look how they spend their money. So, a lot of what we talked about had to do with how do you finance things so that you really are putting equity at the forefront. And so we hope this gives you some ideas and then also shows some possibility as we look at the progress that has been made so far. So we'll turn it back on over to the facilitator, Senator Bullock, for questions.
Well, thank you, Dr. Anderson and Mr. Jordan. That is, you guys are doing some incredible work. I see some comments or questions coming through the
There's
chat
one from
box.
Senator Sims.
Okay, I'll have somebody ask that question, or we bring Senator Sims to ask. But we did post your link to your reports in Kansas, and you said something awfully important, Dr. Anderson. These are issues we've been working on pre-COVID. These are things we've been working on from sickle cell to maternal health and prenatal care and what we call PTSD in the interfamily and intercommunity network. That's trauma that we've been working on. And COVID just put the world on pause for us to highlight, and it magnified it to a different level, as well as some other social injustices around the world and the country. And I just thank you for your tremendous work. And I'd like to make sure that we convene these issues at our next conference with a room full of folks from our provinces and our states so that we can exchange the best practices. And for those on the call, a lot of times, some of this stuff does come down from the federal government, but it's not a cookie cutter process in each state based on each state's laws. And we have to tailor make them to fit our own communities. So, can we have the question addressed, Laura?
Sure. The question Senator L.G. Sims from Illinois asked is, first he congratulated you all on the excellent work and said, could you speak to the challenges you experienced with getting buy-in from parties on both sides? That is, those who thought you might be going too far versus those who thought you weren't going far enough as you work through your efforts.
Senator Sims, I love that question because you're certainly going to have people that'll say that's too much and some folks that'll say that's not enough. And with that, and perhaps Commissioner Jordan wants to tag team on this one. But so here are things that we did. I can share with you, we talk about being preventive and proactive. So when we posted this report, we didn't just post a report like many people do and they say, here's the report and it sits on the shelf. We then began to educate because I think the questions are good. And for those that say you didn't go far enough or you went too far, I think those become opportunities for dialogue and discussion because, we only speak from what we know. So seek to understand in order to serve was really our approach. So that seeking to understand led us to providing multiple webinars. Commissioner Jordan will talk a little bit about those webinars and what those look like. We also did op-eds almost every month. So even if you weren't a legislator, if you just lived in the community and you wanted to write to your senator or you wanted to write to your legislator, that really changed the conversation and made much more bipartisan support because we were building a different kind of narrative. The other thing is myself and my co-chair, she and I both presented to the legislative body multiple times. In a few weeks, we'll be presenting to KBOR, the Kansas Board of Regents. We have a number of recommendations on education, diversity, and teaching. And just some small things that can be done immediately to change Kansas. So those are things that we've done to get that support. And so that having the conversation has been key outside of the legislative body. So, us saying, hey, let's have the conversation and sharing these narratives. Commissioner Jordan, you want to add to that and to share the webinar series and what that looked like that really led to greater bipartisan support?
Sure. Thanks, Dr. Anderson. Well, I think two things. One, in terms of, we wanted to be strategic and start educating legislators on both sides of the aisle on some of these key issues. So take postpartum coverage, for example. We presented to the interim committees on mental health modernization and the CanCare Oversight Committee to help educate both Republicans and Democrats about this issue. And we had appropriate spokespeople, and it really took an outside strategy to bring in mothers that were affected. Dr. Charlotte Smith from the Kansas Birth Equity Network did a lot of great advocacy, as well as key constituency groups like the Association of Community Mental Health Centers, who the Republican chair of the House Healthcare Committee really listens to. So we built those coalitions and worked both through the governor's budget process, but also made sure those interim committees were aware of policies. And I just use postpartum coverage as an example so that it was easier to bring this policy up. Now, did this go as far as we want? This was an interim win to extend postpartum coverage. We're still one of those 12 states that didn't expand Medicaid. We really need to expand Medicaid, but we're happy that these 9,000 mothers are going to have coverage, and we can address some of these significant disparities in the first year of life and hopefully save some lives. But as Dr. Anderson said, we really wanted to have outside groups own this report. So we've done a number of webinars, focused on state administrative recommendations, legislative recommendations, and local recommendations so that we can build some momentum over time. And so these groups have the blueprint to use from the report, but are engaged and can be part of the success. So I think that we're hopefully we'll see more progress because we've done the education side. They can see themselves in this report because they participate in the whole process, and then they can carry some of these recommendations forward. I think we always want to go farther, but we need to get some wins along the way to build momentum. And I think we're excited to see what we've done this year, but we know there's more work ahead. As Dr. Anderson said also, our real big thrust is to make sure this report just doesn't sit on the shelf. So beyond doing those webinars that have engaged 150 stakeholders each along those different recommendation areas, state, local, and administrative, we're also doing a monthly column, Dr. Anderson, Dr. Portillo, and I, who chair the different committees on the commission on the different themes. Because 160 recommendations is a lot. It's a lot even to just decipher it down to a monthly op-ed, but we're hopefully making sure these recommendations are real and continue to be seen by people. So we really want to keep working on this, even though our formal role on the commission and today's discussion is important too. So thank you.
Again, I'd like to really, really, really thank Dr. Anderson for her commitment to this work. And you have to go, and Mr. Jordan's going to stay on the call. We're going to keep moving so that we can have a broader conversation and dialogue at the end of this presentation. So right now, I'd like to bring on our next presenter. In 2021, State Senator Maddie Hunter was the lead Senate sponsor on House Bill 158 in Illinois, which addressed systematic inequities in the state's healthcare system and services. Senator Hunter has served in the Illinois General Assembly since 2003. She serves in leadership as the Majority Caucus Chair. She is the chair of the Revenue Committee and is the vice chair of Ethics and Executive Appointment Committee. She is serving Illinois' 3rd District located in Chicago, and Senator Hunter has sponsored over 400 bills addressing breast cancer, healthcare access, substance abuse, youth employment, environmental issues, and education. So welcome, 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 Senator Hunter.
Thank you so much for that introduction, Representative Bullock. And I also would like to thank Council on State Government for holding this forum. Is very, very important. I really did enjoy hearing the other presenters. And so last year in 2001 and part of 2002, during the pandemic, the Black Caucus came up with 4 pillars, which you see on the screen. These are issues, equity issues that affect our community. We've been introducing legislation. I know all of the 20 years that I've been in office, especially as it relates to health and human services, which is my pillar. It was the last pillar that came on board, meaning being passed. And so I had passed probably 20 or so bills dealing with diabetes prevention, cardiovascular diseases, respiratory illnesses, clean air. I mean, you name it, I've done it. I passed these bills and they were unfunded mandates. The administration was never able to find the dollars, to go into the areas of the my district, as well as the Black community, the Black and Brown community, to address these issues. And so myself and one of my representatives in the House, Representative Camille Lilly, we took a look at a number of bills that not only she and I had been introducing and sponsoring and getting passed, but we took a look at about 50 bills that many of our members had passed over the years. And the same thing had occurred. And so we said, well, you know, had these bills been implemented and properly funded, we probably wouldn't have as many disparities as we have in our community today. You know, I walk through and I ride through my district. I live on the south side of Chicago, and I walk and ride through the west side of Chicago. And all I see are so many people in wheelchairs. They're walking on walkers, you know, and these people are sick. You know, so many, you drive through our community and, you know, you have kidney dialysis companies all over everywhere, you know. And so we do have in our community food deserts. All you have are fast foods, restaurants. People are no longer grocery shopping and cooking their own meals. And so there's a unhealthy diet that's going on out there as well. So we got together and decided that we need to put together some sort of recommendations on how to deal with equity and diversity and how to correct these issues. So the first person, well, and then of course, COVID hit. And it really blew up the whole situation. All of the Black and brown folks that we kept looking at, they started dying. You know, they were dying, you know, at a very high rate disproportionately. We looked at some statistics, and we found that Black folks on the south and west sides are living like 11 years less than the people downtown on the north side. And we kept questioning, why is this happening? What is really going on out here? You know, we knew that our healthcare system in Illinois simply was not working for a certain group of people, okay? So we came up with pillars. We talked to many of my colleagues about this issue, and they were African-American, they were Latino, they were Caucasian, and everyone is noticing the same thing, but as legislators, we're spending more and more and more and more monies on addressing these disparities. And so we said, well, we cannot continue to spend all of this money and getting low outcomes, or very, very little outcomes rather, I'm sorry. And so we decided to go to our strength, which are to talk to our community-based advocacy programs. The agencies throughout the state that we've been working with over the years to help us pass legislation. So we met with primary healthcare providers. We met with behavioral health organizations. We met with, oh my God, we met with all housing advocates. We met with all kinds of different organizations, and they explained to us all the different issues that they were experiencing, which is what our observations were as well. So we decided to hold hearings virtually because of the pandemic. We were not in session. So we held hearings, and we were literally holding like 3 and 4 hearings, sometimes a day. The hearings took place 2 and 3 hours, very, very long hearings. We met with the hospital association, you know, and some of our changes were quite aggressive, and they were sort of kind of pushing back on us, you know, and they were trying to slow us down. Well, why don't you try this? Why don't you try that? We knew that a large number of people were members of the managed care companies where they were receiving their health care. So if you talk to many of those folks, they were saying, well, I am really not getting the health care that I feel as though I deserve, you know. And so we knew that that was an issue, and we knew how much money we in the state of Illinois was spending with the managed care companies. There was a shortage of staff. The behavioral health organizations were complaining that they have major shortages because the managed care companies were hiring them off of them, and they were paying them more money, almost doubling their salaries. So, and then we already knew before COVID there was a nurse shortage. There's a healthcare worker shortage. And so we have all of these different issues that are impacting our community. In addition, in the middle of COVID, one of my major hospitals, safety net hospitals in my district, was closing down. Now, how in the world can you close down a major hospital in the middle of a pandemic? So we were juggling a lot of balls. We were organizing community organizations. We were organizing the unions. We were organizing all kinds of grassroots community leaders, ministers. Folks was all coming together. We had marches. We had car caravans, press conferences. The press stayed on it. The written press and the electronic press. And so there was a lot of things going on, you all, at the same time. And we're trying to juggle all of these balls and trying to figure out what in the world is going on. So we talked to the governor's office and asked them to weigh in on what the heck is going on. And we told them, you cannot allow this hospital to close. You just cannot. I'm sorry, you just cannot. So we had begun to find people who had the financial means to keep the hospital open. So we were juggling a lot of balls, as I mentioned earlier, and we knew that we needed better access to healthcare. We knew that we had to prevent my hospital, my district, from closing. And then we hear that there are 2 other hospitals within the state that were threatening to close, but it was very quiet. And the pandemic is still going on. People are getting sicker and sicker and sicker and sicker. And then many hospitals were saying, well, we cannot afford the maternal and infant mortality. We cannot afford these units in our hospitals. That's the first thing to go. So then we said, well, where are these women going to go to have their babies if you keep closing down these maternity wards? And then, of course, there's a high rate of African American and other minority women who are dying in childbirth. Okay, so we were trying to rack our brains to try to figure out how to address all of these issues. And we started with the legislation that we had attempted to pass a long time ago. So we started pulling all of those pieces together. We received a tremendous amount of information from the hearings that we held through our providers. And we realized that one of the most important components of everything, and everything was very important, but the community health worker, they were more important than anything because they were the link from the field to the community. The community health worker, these guys are the ones that are sent out from different organizations that they work with. They have some sort of medical training, and they are the ones that go out and knock on someone's door, especially a pregnant woman who really needs healthcare and needs to make sure that she is going in to get her getting her physicals to make sure she has a healthy child. These are the people who are making sure that Mrs. Jones' prescription should be filled on a regular basis, or do you need any services? Do you need transportation? What do you need to make your life easier? We knew that we had some major issues dealing with the implicit bias amongst our healthcare, our medical providers. They needed education, and so we kept saying, well, in terms of equity, are the hospital leaders, does the primary healthcare workers, does the administration, are they all on board with how we feel about equity. Do we understand? Are we on the same level in terms of understanding what equity really is? What does it mean to you? What does it mean to you? So then we wind up creating this all kinds of commissions, task force, advisory committees to take a look at across the spectrum all of these different issues. And we wind up having to put together a very massive omnibus bill, you know, and it took us a long time to put this whole piece together, but we finally got it done. And I must give credit to my Senate President, John Harmon, because there were a number of our Democrat colleagues who were not on board with transforming the system. So to his credit, during a pandemic, he brought all the 42 Democratic senators to the state capitol, put us up in a hotel, and he brought in some expert trainers from our universities. And they came out and they provided a day and a half sensitivity trainings. They had to desensitize many of my colleagues because they were either confused or they just simply didn't understand this thing about diversity, inequities. They had all kind of biases, but that they were not aware that they presented these biases. And so there were tears shed, which was good. And a lot of folks understood. They said, now I understand why this is happening and that's happening and why it costs so much money, and we got to fix this thing. And that's what we wanted to hear. Let's work together as a team to fix this whole situation. We're spending so much money, so perhaps we need to redirect some of these monies in the areas with the greatest need. You know, why are you constantly putting more monies in the same areas and you're getting better outcomes, but then you're putting less dollars in the areas that with the greatest need? So that's actually how we put together House Bill 158, our Health and Human Services omnibus piece of legislation. We spent sometimes all night on the floor, on the Senate floor and the House floor, debating this issue. Sometimes we did not get out of session until 4 o'clock in the morning after coming into the building at 9 o'clock in the morning. Okay. After we would leave, sometimes we would adjourn 10, 11 o'clock at night from the floor, and we had to hurry up and get home or to our hotel room or wherever you're residing. And we had to get on another Zoom link meeting so that we can further have discussions with different advocacy groups, because we had to bring everybody together in order for this thing to work. So where are we now? We are in the process of implementing the advisory boards, the task forces, and we put together an oversight commission that will oversee this entire operation. And so we've been collecting resumes from experts across the state who can help us make this thing work. And there are some more meetings that we need to have because we've not met with the leadership of our hospitals, you know, the presidents. We want to go straight to the top. We don't need to deal with the lobbyists or middle management. We need to go straight to the top to make sure that everyone is on board. We need to have bring the insurance companies to the table, okay? Because they're the ones that are paying for the insurance as the insurance providers. And so that is exactly where we are. And I just hope that I didn't confuse everybody with so many different pieces out there, you know. But Rep. Bullock, I'll turn it back over to you for any kind of questions anybody may have.
Well, thank you for all you're doing in Illinois, and Senator Sims is a great leader over there and making things happen. What we have now is, we have any questions, please put any question you have in the chat box or raise your hand and we will try to address that. But just in general, just think about what you're doing in your state or what's going on in your state. If anybody like to share an effort or some type of proposal or initiative they're undertaking in their state to address healthcare disparities, please open up and let us know. There might be ideas or things that we might take from that or something from the conversation today you might take and be able to tailor make to fit the laws and the statutes in your state to make some effective change. Do we have anybody, Ms. Laura? You know, and I talked to
I
other,
don't see anyone yet. I'm sorry.
I talked to other like as the chairperson of the Michigan Legislative Black Caucus, I talked to my Illinois colleagues, I talked to my Kansas colleagues, my Wisconsin colleagues, and no matter how we list our 4 or 5 priorities, they are all the same,
Yes.
just with different priority numbers. Like, you know, healthcare disparities was our number 1. I saw that she listed it, but they're not necessarily outranking one another. They're all equally as important in the urban community. So healthcare disparities, workforce, labor, economic development. Like I said, we're trying to rebrand criminal justice. It's a word that never sat well with me even as a kid.
Right.
And so we're trying to call it peace and justice, you know, because you're supposed to be innocent until proven guilty, but we know that's not how it's implemented. And then the last one is education inequity. So all of these things go hand in hand, and with racism being a public health crisis and how it affects communities across our state or our states, just from the federal government's laws that are confusing and convoluted and tie bar to other laws that you can't make changes to until you go back and change the constitutional piece, and then you come to your states and you got to go address. But there are some things we can do together to make some immediate impacts.
Right.
Sylvia Santana, my good colleague from the state of Michigan, is on, and she is going to verbalize her question.
Yes, one of the things I have sat on the Health and Human Service budget for 5.5 years, and now as a minority vice chair, I'm finding it more and more complex to take care of some of the priorities when it comes to health disparities in communities of color. I mean, my colleagues across the aisle have definitely shown where they want to prioritize dollars. And, one of the things that I've taken from this conversation is definitely trying to have those conversations around empathy, as well as have those conversations around just understanding where they're coming from their perspective. But I want to ask strategically, I know that Senator Bullock has mentioned that has been conversation with all of the chairs of the legislative Black caucuses across the country. Has there, and I did hear some of the best practices out of Kansas and what they've been able to do, but are there any other outcomes that have been strategically beneficial to the work and being able to get work moved forward when it comes to appropriations, or even, just making sure that your colleagues across the aisle or colleagues in general understand that how this appropriations will benefit the community and the outcomes from that. So in other words, have they been able to see the investment physically and in person and see how that has helped benefit the communities and want to invest more?
Yeah, I can start out by answering that question. Our Senate president made it possible to make sure that some of the dollars that we needed were funded, were put into the budget to fund these initiatives in terms of implementation. And then we went further than that by talking to the governor's office. And he also was able to help us put line item dollars in the budget to help implement these issues. And some of them were not new initiatives. Most of them were not new initiatives. And so it was basically just a matter of expanding the dollars and expanding the programs to cover more lives, you know? So, and it helps when you're in the majority as well.
That's exactly
You
what I
know.
was going to say to my colleague
Yeah.
Sylvia Santana. Like, Illinois the Democrats run, they're in the majority where we're in the minority.
Correct.
And so we have the only backstop we have to a lot more ridiculousness is that we have a Democratic governor
Yes.
who can veto some of the madness
Right.
that comes out of our legislature. But yeah, but it's a tough do
It is.
to
It is.
get someone to understand and hear your story from your community versus their community. And that, sometimes they think they're on the same plane and they're not.
They're not. Correct.
And
Correct.
so we just had this conversation yesterday as Senator Santana is on our approach here, and we were talking about some things and some racial disparities and highlighting things. And I was like, they just said no to the budget to that. And I was like, what do you mean they said no to that in the budget?
Right. Correct. That was a good question. Thank you so much, Representative Santana.
I see my good friend Rep Stubbs from out of Wisconsin. Are you joining us today?
Yes, I am. What an outstanding presentation. As always, you've done a phenomenal job. I must say, I've enjoyed the presentation. And just a quick update from Wisconsin Legislative Black Caucus. I am the chair. And we really was very active in our criminal justice reform work. So I served as the co-chair on the Speaker's Task Force on Racial Disparities. We introduced 18 bills that's bipartisan. I'm happy to share with you 7 of those bills are now law in the state of Wisconsin.
Great.
And I worked very closely as the co-chair on the use of force definition. Unfortunately, we had a shooting of Jacob Blake that was around the world. He's still living, thank God he's living, but his incident certainly made us be more progressive in getting this work done. So it was the lead work of the Wisconsin Legislative Black Caucus that really did that. As far as other work that I've been very instrumental in doing, introducing a bill to create an Office of Equity and Inclusion. We are in the minority, meaning the Democrats are in the minority in the state of Wisconsin, very much so. Like, Michigan, thank God we have a Democratic governor who was able to veto some really bad bills. But in fact, what he was able to do with the bill that I introduced was he was able to write it in, because it wasn't going to be a bill. He was able to write it in different aspects and create different opportunities within the state of Wisconsin. So we can begin to work on the health disparities and the criminal justice disparities. So he was really, really helpful in getting that work done. And so there's still progress in the state of Wisconsin. I mean, we have the worst disparities in the nation. Milwaukee is the worst place to live. But we are certainly beginning to work on those disparities one step at a time. In addition to that, I introduced a Birth Equity Act, so we call it BAE legislation. It's a bipartisan piece of legislation. Unfortunately, it did not get past this session, but we're going to go back at it. And it's working on our birth infant mortality rate, where Wisconsin is the absolute worst. Our babies are dying as soon as they're being born. And so we got to make sure that we're giving out the care that we need to for our mothers. So I appreciate all the conversation that we have. I have 2 colleagues on that's joining from Wisconsin, Representative Vining and Representative Billing, who are here to attest that in Wisconsin, we are working hard, but again, we are in the deep minority.
Well, thank you, Rep Stubbs. It's good to see you. Tell your husband I said hello. And unfortunately, we were trying to be proactive prior to COVID about some things in criminal justice reform. However, it wasn't until the George Floyd incident happened and Ahmaud Arbery that we started to try to move some legislation forward bipartisanly, and then it kind of drifted away. But in Michigan, we just had an incident where a young black man was shot in the back of the head by an white officer, and so now it's picking back up, and hopefully that momentum will actually get us to some real legitimate change in Michigan. But other than that, is Senator Sims still on the call, since he's very instrumental in some of the things that we do? But for CSG, is it possible for like the caucuses, the legislative black caucuses, to upload information that they're all putting in into one portal and in the provinces, and then we share that with our members?
That's a really good idea, Senator Bullock. We'll talk about that with the
In the steering committee?
steering committee on social justice. And as you know, we are wanting to move this into a, membership of all of all legislators, any legislator who wants to join. So let's talk about that in the steering committee, and then also as an ongoing thing.
Okay.
Really great idea. Thank you.
Is Senator Sims on still?
I don't think he is, but he will be, he'll be leading the next webinar we're having. We've had a two-part series on
Our Friday, May 13th webinar on
right.
criminal justice police reform. He's going to be leading that next month. So I encourage you all to sign up and attend that next month webinar.
Thank you.
Yeah, you'll get more information on that, and I will also have the PowerPoint presentations and a link to the full webinar itself on our website in the coming days.
Thank you. I have to run. I'm sorry. I'm
Well, that's
late for the
fine.
event.
Thank you so much, Senator Hunter.
Thanks, guys. Appreciate
Thank you,
This
Senator
was
Hunter.
awesome.
I want to
Great
thank
job.
all the presenters today
Thank
for
you.
a fabulous job, and everybody who has logged on and taken the time to sit through our presentation. There's a lot of valuable information. There's some great progress being done, but just like anything else, there's much more work to be done. So we just like to just continue our efforts and working on our endeavors and making sure that we can address these issues. They are truly needed to make sure that the greater good prevails.
Thank you for your overall information, Samantha, on showing which states have done some work in areas that could draw down federal funds or increase coverage, healthcare coverage, and the various ways that states, several states have looked at addressing various inequities. Appreciate all your information.
With that, I think we can conclude, Miss Laura.
All righty. Thank you so much, everyone.
Thank
for
you,
joining us.
thank you, CSD MLC team, for putting on these series of forums, and everyone else. Enjoy the rest of your weekend.
Thank you.